Okay, Addison's disease. Addison's disease is primary adrenal insufficiency. Now, the problem here is with the adrenal gland. However, adrenal glands, there are two parts of it, right? We have the adrenal cortex and the adrenal medulla. Now, this problem is with the adrenal cortex. There are three hormones produced by the adrenal cortex. In the female, there are three. We have the salt, sugar, and sex hormones. In the male, there's the salt and sugar hormones. The salt hormone is aldosterone. The sugar hormone is cortisol. So when we say primary adrenal insufficiency, so that means what does insufficiency imply? Okay, there's not enough salt, sugar, and sex hormones. Okay, so we call that Addison's disease. Since it's primary, where's the problem here? Because we know in endocrine problems, the master gland is which gland? The pituitary gland is the master gland that controls all other endocrine glands, correct? Right. So in this problem, since it's primary adrenal insufficiency, which is problematic, the adrenal gland or the pituitary gland? This one is a adrenal gland problem. It's its primary adrenal insufficiency. Okay. So we call it Addison's disease. When the patient has this, that means the patient has insufficient amounts of aldosterone, insufficient amounts of cortisol, so not enough salt and sugar hormones. Now, what's the purpose of aldosterone and cortisol?
Aldosterone retains salt in water.
All right, so aldosterone is an emergency hormone, correct? It helps build blood pressure up, build blood volume up, and this is part of the renin-angiotensin-aldosterone system. So is it necessary to have the salt hormone? Yes, because otherwise, how do we maintain blood pressure up, correct? We can't keep blood pressure up without aldosterone. So if a patient has, and what is the role of cortisol in the body?
Sugar, steroid.
Is it only responsible for sugar?
Steroid.
That is just one effect of cortisol, right? So cortisol basically is a stress hormone, correct? Yeah. So is it released in times of chillaxation or during stressful events? Stressful events, we need cortisol, right? So whatever stress, so you have emotional, psychological, or physical stress, we need cortisol, correct? In order to survive. It's part of your fight or flight hormone. So in Addison's disease, the patient has insufficient amounts of aldosterone and cortisol. So describe what this patient will look like. So what will be the patient's sodium level?
If they don't have enough aldosterone, then it'll be low.
Okay, so there will be low sodium. As a result, what will happen to blood volume?
Low.
Low blood volume, so therefore blood pressure will be low as well. We know the relationship between sodium and potassium, correct? All right, so if this patient doesn't have enough aldosterone, therefore they cannot reabsorb sodium, so what happens to their potassium levels?
It goes high.
Okay, so the patient has hypotension, hypovolemia, hyperkalemia. And then let's go now to the sugar. So if a patient has low cortisol or insufficient cortisol in Addison's, what happens to the patient's blood sugar level? It'll be low. Okay, so these are the three main problems this patient will be undergoing every single day. All right, there are other causes. Basically, Addison's disease, we don't know the exact cause, or doctors consider this an autoimmune disorder. Okay, there are other possible causes though, namely tuberculosis. Other causes here are drugs such as these mentioned here, or cancer has also been blamed as a possible cause of Addison's disease.
Wait, barbiturates for when they daydream.
Yeah.
I know.
Phenobarbital, yeah. Okay, there's also a secondary adrenal insufficiency. So remember, Addison's is primary, right? Primary adrenal insufficiency. We also have secondary. Secondary is caused by sudden cessation of exogenous adenocortical hormone therapy. You remember in pharm when you're told that when you're put on steroids, how do you stop the steroids?
Don't stop naturally.
How do you stop it? Okay, so what were you told will happen if you suddenly stop it instead of tapering it? What were you told? What will happen to you? Were you given a reason? Or you just take it, okay, yeah, all right, I'll remember to taper it. Were you given a reason? I'm sure you were. Do you remember the reason? What could happen? This is what's going to happen. So you'll have adrenal insufficiency as well, which is, what are those three problems again? Hypotension, hyperkalemia, and hypoglycemia. Okay, so you'll have exactly the same problem. But this time it's secondary though. It's not autoimmune. This is your fault. Okay, because you suddenly stopped taking the hormones, the steroids. Does that make sense? Okay, so those are the problems here. So what do we do? So let's look at manifestations first. So if your sodium's low, blood pressure's low, potassium's high, sugar's low, what would be manifestations? Manifestations of those conditions. Okay, so what happens to heart rate?
Increase.
High. Blood pressure is
Low.
low. So cardiac output is
Low.
low. So all the signs and symptoms of low cardiac output and also hyperkalemia and hyponatremia. Okay, so this is the condition, the group of signs and symptoms the patient will have. Are these life-threatening?
Yes.
Yes, any one of those three is life-threatening, right? Hypotension can cause shock. Hyperkalemia can cause cardiac arrhythmias, and you'll die with severe hypoglycemia, correct? All right. Now, if you have Addison's disease, you don't necessarily die because these are manageable levels of hypotension, hyponatremia, hyperkalemia, and hypoglycemia, meaning they're not severe. However, there is a life-threatening condition called adrenal crisis or Addisonian crisis. We'll talk about when the patient with Addison's disease can develop Addisonian crisis or adrenal crisis. Okay. So when can you sustain this life-threatening complication, this life-threatening Addisonian crisis? Characteristics are, again, severe hypotension, severe hyponatremia, severe hyperkalemia, severe hypoglycemia. Okay, we call that Addisonian crisis. Now, what would trigger this condition? Okay, so here we have slight overexertion, exposure to cold, acute infection, or decrease in salt intake may trigger Addisonian crisis. So basically, something stressful, right? Does that include surgery?
Yes.
Does that include, let's say, if I have Addison's crisis and then Christina dumps me?
Yeah.
Can that trigger Addisonian crisis?
Yeah.
Yes, so something stressful, okay? Physically, emotionally, or psychologically stressful, such as these I highlighted, can cause Addisonian crisis if a patient already has Addison's disease. Are we clear? All right. So can hospitalization trigger it? Yes, hospitalization is stressful, right? Or what about any procedure? Say a surgical or diagnostic procedure. Yes, it can trigger it. I have no questions on the diagnosis because the doctor simply orders a lab test, and then the phlebotomist will come and they'll do the test. The nurse really has no role in the diagnostic procedure, so we'll skip that. Let's go straight to management. Now let's separate management for Addisonian crisis from Addison's disease. Of course, there's a difference, right? Meaning the life-threatening Addisonian crisis, of course, requires fast interventions, right? Because the patient is going to die. Okay. So let's discuss the management of Addisonian crisis first. So again, these are life-threatening severe levels of hypotension, hyperkalemia, and hypoglycemia. Can you choose which one you manage first?
No.
Is there a choice? Like, I think I'll prefer hypotension over hyperkalemia and over hypoglycemia. Can you choose? No. So can one nurse handle this like a Superman? No. Is this patient on a regular med-surg floor?
No.
This patient will go to ICU. Okay, this patient is going to die. Right? So we need critical management. So we'll have to manage all three at the same time. Manage blood pressure by increasing it, lower potassium, and increase blood sugar. Okay, so let's go. First intervention will be fluids. Okay. So here, because the blood pressure is low, so what position do we place the patient? Recumbent. Okay, so this is our goal. We're gonna give fluids, we're gonna give steroids, vital signs, and then position the patient. Okay. So what's the purpose of recumbent position? Okay, so this is also called modified Trendelenburg, right? So patient is flat with legs elevated. This will promote venous return, increase blood return, venous return, increase blood volume, increase cardiac output. Hydrocortisone IV will be given. Lots of fluids. Look at this, 3 to 4 mLs of NS or D5 dextrose, or D5 solution. Sorry. The beauty of dextrose versus normal saline is this is killing two birds with one stone because this will increase blood volume plus also increase blood sugar. But obviously, is 5% enough to raise blood pressure?
No.
Not really. So we're going to give more dextrose on top of this as well. But don't worry, because the other intervention besides fluids is hydrocortisone. Hydrocortisone is cortisol. Okay, so this will increase blood sugar as well, plus increase blood pressure at the same time. You understand? All right, so these are our interventions. And of course, the other interventions here will be, of course, to address what triggered the crisis. You have to address that as well. So let's say it was infection, it was sepsis that triggered the Addisonian crisis. So you administer antibiotics. So just like you did with septic shock. Are we clear? All right, but these are your interventions. So expect to give hydrocortisone. All right. So this will be powder injection. Powder, you of course reconstitute it, give it IV push, and then this will not be a one-time dose. So you'll give hydrocortisone IV, then expect to give something IM as well, twice a day for maintenance until the patient's condition stabilizes. All right. If the patient is awake, most likely blood pressure is less than 90 systolic, potassium is 6.8 or 7, glucose is 32, 40. Is this patient awake? Is this patient conscious? Probably not, right? Or maybe they are, maybe lethargic, okay, at most or at best. Oral intake, we only give when they're fully awake. Until then, everything's IV. Clear? All right. So these are again to prevent it. So if we know the patient has Addisonian crisis, Addison's disease, when they undergo surgery or they're here for an infection or they're pregnant, for instance, or they're in labor, do we watch them for Addisonian crisis? Yes. Okay. What if, let's say, it's the secondary Addisonian crisis, or a secondary adrenal insufficiency, rather. Sorry, there's no such thing as adrenal secondary Addisonian crisis. So what if they have they're on steroids? Okay, we'll talk about the treatment for this a little bit later. No, let's do it now. So if the patient is stable now, we did the crisis. Okay, we stabilized the patient. Okay, we gave them fluids. We gave them steroids. Okay, we gave them glucose if necessary. Okay. Now continuing care. So how do we treat someone with primary Addison's disease? Primary adrenal insufficiency. We give them steroids for how long?
For the rest of their life.
forever. So they'll be taking steroids for life. So these are the drugs. So they'll be given hydrocortisone for the rest of their life. Okay, so usually the dose is either Predforte, or most common is hydrocortisone. Okay, PO. The patient will be given hydrocortisone twice a day for the rest of their lives. Teaching, of course, is how do you take steroids? Empty stomach or with meals? Empty stomach or with meals? With meals. Okay. And what do you teach the patient? So if this is a steroid, so if you ever heard of people taking steroids, how do they feel when they take steroids?
And mouth will dry.
Or you guys, maybe you had a respiratory infection, you were given steroids for a couple weeks. How did you feel while you were on steroids? Besides your feet puffing up. Wasn't your appetite increased? Wasn't your energy level increased?
Oh,
Wasn't your sugar levels
Yes,
increased?
yes.
Okay. So when do you tell them to take it? Early in the morning or late at night? Early in the morning. What if there's a second dose? What time do you take the second dose? Okay, early evening or late afternoon. All right, never give it at bedtime. What will happen to the patient if you give it at bedtime?
it will be up.
This patient can't sleep. Okay, they'll be up having the munchies. Okay, they'll never sleep. Are we clear? All right. And what are consequences when the patient is taking these for life? What do you educate? Okay, so here's our teaching now. So tell them what the impact of the steroids, why they're taking it. Okay, and then tell them how long do they take it?
For life.
Okay, lifelong treatment. Okay, and then what do they do when they have extra stressful events? Let's say it's exam week. They got pregnant, or they got divorced, or they have a new boyfriend, or they lost their boyfriend. Or let's say they won the lottery, or they lost the lottery. Right? So any stressful event, what do they do? Okay, when they get sick, other stressful events, let's say they have an infection, what do? Okay, they have to increase the dose. Now, they can't do this on their own, though. They have to consult their provider. Doctor will prescribe additional doses during these stressful events. Because otherwise, what will happen? They're taking the same dose, but then their stress levels are increased. What could happen to them? Addisonian crisis. Okay. All right, wear medic alert, because can they ever stop these steroids abruptly?
No.
No. But when they get to a hospital, they're taking these hormones. Let's say they're in the hospital for an infection, or maybe they have surgery. Aren't they NPL? Yeah. So now, how do they take their hormones? They're NPL. Okay, so tell the doctor, and then the doctor will order it IV. Okay, very good. Here, avoid strenuous activity in hot, humid weather. Then, of course, you can't just depend on drugs. You have to have better stress management. Increase fluid intake and salt intake during excessive perspiration. Increase carbohydrate, high protein diet, and read the rest. Okay. Any questions? All right. What if they get so sick they can't take they get the flu, they're vomiting, they have diarrhea, but not sick enough to go to the hospital. But they can't keep the oral hormone tablets down. What do they do? Just crawl up and die? What do they do? Okay, notify the physician. Okay, the doctor will probably prescribe, okay, here's a injectable. Can you give yourself an injection? Or let's say their family member can give you an injection. Or if not, visit the ER. Okay, we'll give you an injection, right? If nobody can give it to you. But we cannot stop the steroids. What will happen again if they suddenly stop? Primary or secondary? It'll be now secondary, right? Any questions? All right, so let's go to the next problem. This is now the opposite. If Addison's or adrenal insufficiency is not enough salt, sugar, and sex hormones, this patient will have too much. Okay. Oh, we forgot to discuss the we didn't discuss treatment. Where were you? Okay. All right, I forgot about the sexual characteristics. So if this patient has not enough sexual hormones, sex hormones, sorry. So what will the problems be? All right, yeah. So the patient, can they have normal menstrual periods? No. Okay, will they have this normal ovulation? Okay, so the patient will have, plus some sexual characteristics also will be a bit weird, right? So they'll have less pubic hair, right? Or maybe their their breasts may not be as as expected. All right, so things like that. Again, in the male, since the male sex hormones are not coming from the adrenal glands, so it won't be any symptoms in the male. Are we clear? All right, let's go to Cushing's now. So now we have too much. Now there's two types of Cushing's here. There's Cushing's syndrome, and then there's Cushing's disease. There's a difference between the two. We say Cushing's syndrome if the increase in salt and sugar and sex hormones is caused by exogenous intake of these hormones, such as treatment for Addison's disease. So Addison's disease patients, remember, they take hormones, correct? Now, will their hormone intake be always adequate? Can it be inadequate? Can it also be too much? If it's too much, then they develop Cushing's syndrome. Any question about that? If the patient's hormone, the salt and sugar hormone increase is due to them taking the tablets, meaning they're being treated for Addison's disease, they're treated for, let's say, some autoimmune disorder, right? Because they take steroids also. So if that's the case, then if they end up with too much dose of the hormone, they will develop Cushing's syndrome. Okay. If the patient's salt and sugar hormone increase is not because they're taking tablets, exogenous sources, if the salt and sugar hormones are high because their own body is producing too much of it, then that means it's Cushing's disease. Are we clear? Okay. If it's Cushing's disease, the problem usually is either primary, which is an adrenal adenoma, meaning they have a tumor in the adrenal cortex producing excessive salt and sugar hormones, or it can also be secondary, which means there's a tumor in the pituitary gland, which causes increased adrenocorticotropic hormone, which stimulates the adrenal gland, right? So the tumor can either be in the adrenal gland, which is primary Cushing's disease, or it can also be secondary Cushing's disease, which is caused by a tumor also, but this time the tumor is in the pituitary gland. Any question between the two? All right, let's see. So now if you have too much salt and sugar hormones, what will happen to the patient? Let's start with the blood pressure. What will it be? High. What happens to the sodium levels? So what happens to the blood volume? High. What happens to the potassium levels? Low. What happens to the sugar levels? High. Okay, so these are the problems. Okay? Correct. All right. By the way, in Addison's, we didn't discuss treatment for hyperkalemia anymore because we did that in fourth semester, right? First module, we discussed, yeah, calcium carbonate,
Excellent.
yeah, by sodium bicarbonate, insulin with dextrose,
Excellent.
sodium cholesterol, sulfonate, as well as patiromer, right? So we discussed all that already, so I'm not repeating it. So here, what will the patients, let's start with the manifestations first. So your blood pressure's high, your blood volume's high, your sodium is high, your your potassium is low, your sugar is high. What will be the manifestations? Because what will the body do with excess blood sugar? Turn it into fat. So speaking of fat, patient will have fat deposits everywhere. So starting with the back of the neck, so the patient will have a buffalo hump. There will be abdominal obesity. There will also be fat deposits in the thighs, in the arms. And because of the increase in blood volume, blood pressure will increase. The patient may have fluid overload manifested by heart failure. There will be edema, dependent edema specifically. And the skin will also be stretched because unlike obesity, wherein it took time for you to gain weight, correct? Meaning if you gain 50 pounds, will that happen in 3 days or over several months? Several months, right? Right. But here, this is not ordinary obesity. This is Cushing's syndrome or Cushing's disease. So the fat deposits here, the obesity occurs over a short period of time. So what will happen to the skin? There will be stretch marks. There will be striae. The skin here will be thin, putting the patient at risk for injuries. Okay, they'll have skin tears easily. Plus, what happens when you have high stress hormones? What happens to your gastric acid secretion? Increases. Can they have stress ulcers now? Yes. Because now they have high acidity. Can they absorb calcium properly? Plus, there is now increased fat deposits. To what happens to muscle integrity? So muscles weaken, correct? And what happens to the bone now? Density. Okay, so the patient develops osteoporosis as well, so in addition to ulcers as well. Patient will have weakening of the bones, therefore, so when they fall, which they will, they'll have pathologic fractures as a result. Okay, and not to mention again, the high blood sugar will cause cardiac problems. All right, some of them will develop also secondary diabetes, okay, as a result. So there's muscle wasting here, excessive protein catabolism, muscle wasting, osteoporosis. They'll have posture problems, kyphosis, backache, compression fractures. Okay, and then the heart failure, as already mentioned, the moon phase. Okay. So in the sex changes, you'll have hirsutism. So they'll have hair, facial hair. They'll have hair in the legs. Okay, increased body hair. Libido is lost. Okay, they'll have depression as a result. Imagine having this and you're 20 years old. What will you feel like, Miss Leah? All right. Okay, and you're still single. Oh my goodness. All right. And then you look like this. Okay, so here are the system by system manifestations. Chart 45-2. I won't read that for you. And here's what you will look like. This is female. Okay, this is a female patient. Okay. Please don't laugh. Okay, these are real people. Laugh later in your own room. Again, we do not take part in the testing, so there's really no nursing role here, so we'll skip that. So if these blood tests are normal, that means it's not primary Cushing's disease, so it must be secondary, right? So if it's a secondary, then they'll check for a tumor in the pituitary gland. Let's go to management. Since they have high steroid levels, so high sodium, high salt and high sugar um, hormones. So what will we do? There are drugs mentioned here. However, most people will only be placed on drug therapy for a short period of time because is it really practical? Because remember, what causes Cushing's disease? A tumor, correct? And a tumor in the adrenal gland, or if it's secondary, there's a tumor in the pituitary gland. So what's really the cure? Surgery. So surgical removal of the adrenal or the pituitary gland. Okay, so let's talk about the surgery. If it's the pituitary gland that will be removed, we call that hypophyseectomy. Okay, let's go to chapter 61 for the pre and post-op care for transsphenoidal hypophyseectomy. So go to chapter 61.
Winter is over.
Okay, sorry for the technical problems. All right. The transsphenoidal approach, this is the best way to do hypophyseectomy because instead of opening your skull, since the pituitary gland is found between your eyeballs, okay, right here in the front of your skull, so it's better to remove it through your nose. So we will remove the sphenoid bone and then put surgical instruments through your nostrils and then remove the pituitary gland and the tumor through there. Yes, 2016. Okay. So this will give you the least invasive way to remove the tumor. Okay. Of course, is this brain surgery? Yes, this is still brain surgery. Okay, you just did it through the nose. So problem here will be, of course, could there be a CSF leak? How do we test for cerebrospinal fluid again? Yes, Rosal, what do we do to test if the drainage is CSF versus something else? You're looking for what sign? The halo sign. Okay, very good. So will the drainage be bloody? Someone did surgery through your nose. Will the drainage be bloody?
No.
Someone did surgery through your nose. Let me put instrument through your nose and see if it's not
It's
bloody.
not gonna be, it's gonna be bloody?
It's bloody. Let's see right here. It's going to be bloody, right? And there will be a plug into the nose. So they'll pack your nose with dressings. And of course, part of the procedure, there will be a small incision at the roof of your mouth. Okay, so that's how they do the procedure. So of course, can you brush your teeth afterwards? It's not safe because you might hit the incision, right? So you'll have oral rinses instead. So you'll be given antiseptic mouthwash. And then there'll be a packing in your nose. So how do you breathe? Through your mouth. Okay. So you'll have a mustache dressing. The mustache dressing will catch, the bloody drainage. And then again, we check it periodically for the halo sign. You dub it with a clean white gauze, and then if there's a ring around the blood, then that's CSF. Okay, so you test for that periodically, and it's brain surgery. So what are we concerned about? Increased intracranial pressure. So what are activities again that increase ICP? Coughing, sneezing. Okay, yeah, sexual intercourse, bending over, pushing, pulling. Okay, straining. Right, correct. So all of these are going to be prohibited. Okay, so how do you prevent coughing? You give cough suppressants. How do you prevent sneezing? You give antihistamines. Okay, so how do you prevent straining? You give stool softeners, right, etc. So that's what you do. So any questions about pre and post-op care for hypophyseectomy? And then please keep in mind this section here talks about diabetes insipidus and SIADH, which are complications of brain surgery. Is this brain surgery? Yes. And we did diabetes insipidus and SIADH last semester already. Any questions? All right. So let's go back to adrenalectomy now.
Do we need that much for the one? No, I mean the second, I mean. Second.
Sorry, I missed that. What was that?
The surgery part, do we need that part for the second exam? Oh, because. The surgery was not.
What did I say at the start of this section of the class? First exam stops at
Most house.
post-op care. Okay, so we did the adrenalectomy. Let's now go to, no, sorry, we did hypophyseectomy. So now let's go to adrenalectomy. So if the tumor is in the adrenal glands, so we're going to have to remove the adrenal glands. Now, depends now. Are we removing one or both adrenal glands? Okay, so if we're removing one, does the patient develop Addison's disease?
Yeah.
Because now there's no, but we're only removing one adrenal gland. Does the patient develop Addison's disease? No, because they still have another adrenal gland, which will produce the salt and sugar hormone. However, will they maybe require temporary
Yes.
hormone replacement? Yes, temporary for a few months or maybe up to 2 years. But we'll monitor the levels, okay, to see if if it's low, then we'll prescribe hormones. However, if the patient loses both adrenal glands, what does the patient develop now? Addison's disease, because there is no more adrenal glands. So do they still have any salt and sugar hormones?
No.
No. So how do we treat them now?
Steroids,
We give them lifelong steroids because they developed Addison's disease because of the surgery. Does that make sense? Okay. Now let's go to Cushing's syndrome. So if it's Cushing's syndrome, what caused the problem?
Too much steroids.
Too much of the steroids, because you have Addison's, you're being treated for it, right? Or you have some autoimmune disorder and you're taking steroids for that reason. So what do? You took too much of the hormones and you develop Cushing's disease. So how do you think we will manage that?
Stop it. Stop the steroids.
Stop the steroids? What will happen to you? Addison's crisis. You'll die. So give me another answer. Adjust the dose. Because can the patient stop the hormone replacement? They're taking it for a reason. They were taking it because they had Addison's disease. They had autoimmune disease. So they can't go without the hormones. They need the hormones. But what's the problem again? How did they get Cushing's syndrome? We got too much. So all we do is, again, not taper. Because when you say taper, we're going to stop it, right? So we're going to adjust the dose. We gave too much, so we lower the dosage. Okay, so it's gonna have to be, is Cushing's syndrome therefore a one-time event? No, this patient with Addison's disease that's taking the hormones for life will have multiple episodes. Okay, so they'll have Cushing's syndrome again here, so we'll adjust the treatment. Oh, they look better. Then another time comes, oh, here we go again. Okay. So if you're the patient with Cushing's disease, you started with Cushing's disease, what will you end up with? Addison's disease, right? Because the treatment is surgical removal of either the adrenal glands or the pituitary gland. So which one do you want? Addison's or Cushing's? Alrighty, that's it. So we'll have this topic for example.